everybody. Welcome, doctors.
Hello, thanks for having us.
Hi, thank you guys so much for coming. Thank you for joining the first TED Global Conference. Very exciting times with a very fun and often debilitating disease. So I appreciate all you esteemed panelists joining us today. My name is Dr. Layla Lohmann. I am a thyroid eye disease and Graves' disease patient, as well as a healthcare professional in the oral space, also known as a dentist. But I like to consider us the primary care providers of the oral cavity, and it'll catch on one of these days. But today, I'm just so glad that everyone is here to join us for the kickoff of learning about thyroid eye disease from TED to NED and getting connected. We're going to be digging into the science behind thyroid eye disease today. And as a patient and clinician myself, I know how overwhelming it can feel to understand what's actually happening inside our bodies. So this session is about making the science approachable and giving you clarity, not confusion. So I'd love to have the panelists just give a brief introduction of their name, where they live, and their profession, just like 1 minute each. And we'll start with Dr. Pactel. If I said that wrong, I apologize.
Hi, Layla. So actually, it's a pleasure for me to join this wonderful meeting and have a fruitful and constructive, informative session with all of you, my dear colleagues, and our attendees here. So I'm Farzad Pakhtel. Basically, I'm oculofacial plastic surgeon, a professor of ophthalmology, oculofacial plastic surgery at TMS. Now I'm at the Stanford, focused on whole eye transplant project and also working a couple of thyroid eye disease projects at Stanford.
Amazing. We can't wait to dive into this. We'll go with Dr. Landingham or Van Landingham.
Van Landingham, thank you. Yes, thank you so much for organizing, everybody, and Dr. Lohmann for hosting. My name is Suzanne Van Landingham. I am an associate professor of ophthalmology and oculofacial surgery at University of Wisconsin-Madison. So for anybody else, Dr. Hong is also probably experiencing his first day of like 20-degree weather here. It's a big shift. Yeah, and I have my practice kind of covers all of oculoplastic surgery, but I do have a special interest in thyroid eye disease. I've been involved in several clinical trials as well as database style research looking into topics related to thyroid eye disease. So again, thanks for being here, and thank you to everyone for hosting and organizing.
I love that. We're going to have great conversation this first hour. Dr. Hong? You're muted, Dr. Hong.
Sorry about that. So I just want to echo Farzad and Suzanne. Thank you so much for hosting this event, and really looking forward to engaging in a really interesting and stimulating conversation about one of my favorite topics, thyroid eye disease. So my name is Sang Hong. And I am oculoplastic surgeon and a neuro-ophthalmologist, and I practice at the Medical College of Wisconsin in Milwaukee, Wisconsin. Since fellowship days, I've had a strong interest in thyroid eye disease and continue to do so, and have been a part of several clinical trials, including the phase 2 and phase 3 trials that led to the approval of teprotumumab, which is quite exciting to be involved with.
Awesome.
Looking forward to this.
Well, thank you. I feel like I should just get all of your numbers, then I can just text you inappropriately at different times when I'm dealing with something, just like normal patients. No, I'm just kidding. Dr. Ayola Hayedo?
Yes, hello. I'm like a oculofacial plastics, from Miami, and currently working at Amgen. So
Nice.
good night to everybody, or early afternoon for some.
Thank you. Thank you for joining us. Dr. Nguyen?
Well, I guess I'm the second East Coast person here. We did get a a bit of snow flurry already. So first snow for us in the season. But my name is John Nguyen. I'm a professor at ophthalmology at West Virginia University in the Appalachian Mountain. And we'll cover a tertiary referral center for the cover in the region area. And like other panelists, I'm involved in several clinical trials that ongoing. Our practice similar to other panelists, we have a kind of multidisciplinary thyroid disease clinic that we see patients, and very excited to join the panelists and hope to contribute to the conversations about thyroid disease, and also looking forward to learn more about from others.
Well, I am so excited. Just a little bit about me. I've been living with thyroid eye disease and Graves' disease for over 27 years. I was diagnosed at 12 years old, had a thyroidectomy, was told I had severe allergies for most of my life until I got pregnant with my son in 2015, at which point they told me I had an active phase of thyroid eye disease. And I laughed at my doctor and said, "Oh, no, I had a thyroidectomy. You're wrong." Lo and behold, there are two other ways to get it. It's just more common with those with Graves' disease. And so in 2020, I was given Tepro. Well, I'll say Tepezza because that word is a lot harder for me to say. So I'll say the brand name, but it's you have it better, Dr. Hong. But we had done mostly high doses steroids. Pregnancy was difficult, and just became a patient advocate when the medication got halted due to the FDA having to halt all vaccines for the COVID. So I became a patient advocate in 2020. And ever since then, and working with Christine, we realized that there was a lot more to thyroid eye disease than just bulging eyes. And we just built that community around all of us, knowing when our friends would say, just use a different eye drop. And we're just smiling and nodding like a patient would, living with any kind of chronic condition. So this global conference is to connect the dots between what's going on with the science, what's going on with our body, and how do we manage living with this condition without becoming a victim to it, but being able to manage and communicate and connect with our doctors, our patients, our caretakers, and our family and friends. So thank you guys for joining us today, and thank you for everyone who's joining us this week. So I'm going to get started. And I'd like to begin to understand from any of the esteemed doctors, and if I need to cherry pick, I can, but what's actually happening inside our bodies for everybody. And the more lay terms you can use, the better, but I'm also open to any scientific terms.
I guess I could start. I think in terms of thyroid disease, as we all know, it's an autoimmune conditions, where the most common kind of manifestation is in the regions of the eye there. And I think we don't know exactly the triggers of why that's happening. For some people, can occur before that you find out you have typically hypothyroidism or Graves' disease. But for some people, it occur at the same time concurrently, both the eyes and the thyroid itself. And then for some people, it could occur afterwards, meaning that you have a Graves' disease and didn't have any problem with the eyes, and then it happened later on. Like any autoimmune conditions, you have to have a kind of an antibodies, and typically we autoimmune thyroid antibodies, and the antibodies cause a reaction because we have receptors, and for some people, that receptor is more being activated for whatever reason in the eye socket regions. And when we talk about the eye socket here, is we talk about the skin, you can get swollen skin, you can get the fat get swollen, baggy eyelids or swollen eyelids, and then it not only swollen, but it get red, looks inflamed, and then on the muscle itself, you can get muscle swollen, but you can't see the muscle because it's behind the eye. And one thing that it does is it causes some people have double vision. Either it's a transient, and many times patients may notice that they can have double vision, especially in the morning time or early morning when they wake up. And there's some theory of hormonal changes around that time that patient may notice a couple hours for them to to get ready for the day that the double vision goes away. And certainly on the eye itself, that you can get the redness, as you mentioned, people can, you were told that you have allergies. Some people have red eye or swollen eye that people think, oh, you have allergies, you should go get allergies eye drop. And actually, it's still, some people can get delayed diagnosis because of that reason is, primary care doctors, other eye care providers who don't look for thyroid disease can kind of misdiagnose or delay diagnosis because of that. But this antibody, as it's activated, causes the inflammations. And for some patients, it varies. Some people can have more of the swollen eyelids than others. Some people may have what's called a lid retraction, which is a very common thing where the eyelids open really wide. That's what we see. And then for some people, it can be bulgy eyes or double vision, as we mentioned. And the exact, activations of why some people have one or the other, we don't know. And that's why it's a variety of presentation in different people. But that's kind of the happening without going much into detail. But I'm sure my colleagues can mention more of the actual biochemical and the activators of these different antibodies that activate the tissues. Yeah.
Well, so basically what you're saying, and another doctor can definitely chime in, is your body is basically attacking itself. And specifically in thyroid eye disease, it's attacking the surrounding muscles around your eyes, which cause the reactions such as bulging eyes, redness, and all those things. So in reality, if someone potentially may be having thyroid eye disease, but no one's not diagnosing it, if they're having some of these signs and symptoms, what would they say to their doctor? Like, can you check me? Or, this is what I'm feeling. Like, how do we tell people how to speak to their providers about what's going on in our bodies based on what you just said?
Yeah, I think nowadays we find that there's more recognitions of thyroid disease among the referral doctors, but also I think patient educations have been more open. And so certainly I think there's patients who come into my clinic ask, can you check me for thyroid disease there? But I think what we talk about here is, many times patients may already have thyroid and they want to get checked for thyroid disease. But what about, you don't know if you have thyroid, if you have thyroid disease. So I think it's probably one of those things probably should be on the mind when the patient goes see the doctors is, well, I think many times we're all busy and we may not be able to remember everything. But I think one thing I would advise maybe have a diary of your symptoms.
Sure.
And I think it's very helpful to describe to the doctors and I think to the people, the technician who start the workup or the visit with you. And I think having that diary of the changes that are happening and the variations of changes that are happening, I think can be very helpful in terms of to tell about the journey that you're going through, the difficulty you're going through, not just the symptoms, but also we also talk about quality of life. What difficulty do you get with these symptoms? Where you will not work on computers, which a lot of us are working there. What about driving? Relationship wise, how do your own self-esteem or how do you feel out of view about you? And so I think but having to me, I think having a diary or some kind of records is very helpful, as best if you can recollect what's been happening to you.
No, that's great. I think Dr. Van Landingham, did you have something to add about what's going on in the body or?
I think you covered it pretty well. Although I think one thing to mention, and you sort of touched on this, is that when we think thyroid eye disease, a lot of people think it goes hand in hand with Graves' disease, which it often, but not always does. So about of all patients with thyroid eye disease, about 90% have Graves' disease as well. And then another 10% don't. I believe it breaks down to, and somebody correct me if I'm wrong, but I think 6% euthyroid, so like normal thyroid hormones, and 4% hypothyroid or low thyroid hormones. And basically, as Dr. Nguyen was explaining, when our body is making autoantibodies, these abnormal antibodies that attacks our self, in some patients, those antibodies are only targeting the thyroid. In other patients, it's targeting both the orbital tissues, the eye socket tissues, and the thyroid. And in some people, it's targeting only the orbital tissues. So that's how you end up with, most people kind of have both. Some people have one or the other. And I think sort of along those lines, when someone has sort of just thyroid eye disease, they don't also have thyroid hormone abnormalities, we recommend getting labs redrawn every so often, every 3 to 6 months after that initial diagnosis, just to screen for the development of Graves' disease or other systemic or full body thyroid illness.
Well, speaking of that, because you brought it up about Graves and TED together, why don't they always show up at the same time? If you were to technically have that 90%, right? Like I was one of the 90 that I was misdiagnosed with allergies, but they called it Graves with exophthalmos. Obviously, 27 years ago, they didn't talk about TED as openly as they do now. So based on what you guys are learning, like why don't they always show up together? Dr. Hong or Dr. Pactel?
Sure. So sometimes the autoantibodies are targeting the TSH receptors in the thyroid and causing overproduction of the thyroid hormones, and so that's how the hyperthyroidism or high thyroid hormone state results, causing all the symptoms of what we know as hyperthyroidism, with the heat intolerance, heart palpitations, weight loss, things like that. But they don't always target the autoantibodies involved aren't necessarily activating the fibroblasts that are in the orbit. So these are the cells that when they're stimulated, they proliferate, they get larger, they can differentiate into the fat cells and the muscle cells in the orbit, and get enlarged and cause fibrosis or scarring. And then that can cause the enlargement of the soft tissues behind the eyes. They cause the bulging of the eyes and the eyelid retraction, the inflammation that we see in thyroid eye disease. But that doesn't always happen together with the endocrine or the hormonal activation that's happening at the level of the thyroid. So that's why sometimes you can get that I guess disparity. But in most cases, you do have it together, but it can be sort of temporally also not at the same time, where you get the hormonal changes first, and then you get the eye changes. A lot of times, though, it happens at the same time.
Yeah, no, great feedback. I'll get to all the questions on the panels closer to the end of the time. I want to get through a few of our questions, and then we'll coordinate with everybody who's on. So thank you for everyone who's joining us. As we know, women are disproportionately affected from this disease and in many other autoimmune conditions. Do you guys believe with the studies out there that it's more about the hormones or the immune system? And some people, as I've been reading more and more studies, it's been stress. Like the stress level of females comes from a different level than men, and so they tend to have more of these conditions. So, Dr. Pactel, would you mind answering that, and then we'll go through anybody else?
Yeah, thank you very much for asking. I just can add something quickly what actually my dear colleagues mentioned and Dr. Han mentioned about actually the why Graves' disease may not simultaneously appear when we are seeing the ophthalmic symptoms of the disease. So the first thing is that when we would like to define thyroid eye disease, we should understand how we define the disease. If, as my colleagues mentioned, if you define based on the clinical presentation, about roughly half, actually 50% of patients with Graves' disease may develop orbitopathy. But if you look at the orbit more precisely under magnification, like with MR imaging, more than 90% of patients with Graves' disease develop thyroid eye disease. This is the first thing to realize. The second thing is that we should consider that the pathophysiology, although both of them like autoimmune diseases in different organs of the body, but the pathophysiological mechanisms are not the same. We are talking about actually increase in hormone secretion in thyroid gland enlargement because of the follicular proliferation, but we talk about orbital inflammation and tissue remodeling, totally different what we are seeing in the thyroid gland. So basically, the actually microenvironment of the orbit is totally different to the thyroid gland. The anatomic factors are another thing that should be considered, and the way we define the disease is different. So maybe I just wanted to add something quickly to the previous question.
Yeah.
But your question about why actually women are experiencing more commonly thyroid eye disease compared to male patients, basically it's a long actually standing question about why we are seeing autoimmune diseases much more common actually in women compared to men. Roughly, we may see autoimmune diseases, not all, but most of them, 4 times more prevalent in women compared to men. Long-standing discussions about the role of hormones. We know that estrogen increases the efficiency and robust immune reaction. So maybe that's the reason why women can combat infections much better than men. But again, that robust immune actually reactions may somehow increase the chance for autoimmune reactions as well. Also, we are seeing that hormonal imbalances, as you beautifully mentioned, in some periods of life. When we have hormonal disbalances, especially estrogen, progesterone, and also in thyroid gland itself, it may exacerbate the occurrence and exacerbation of the pre-existing thyroid eye disease. So, for example, in different periods of time, like pregnancy, like circadian fluctuations of the hormones inside women's body may perpetuate inflammation based on the underlying autoimmune conditions. And another interesting point is that the role of the X chromosome, it's a long-standing discussions and research. Recently, last year, I remember an article published in Nature showing a new understanding of the role of the X chromosome in women interpreted in autoimmune diseases. So we know one of the X chromosomes in women, we know that in women we have 2 X chromosomes. In men, we have 1 X, 1 Y. In men, both X and Y are active, but in women, one of the X chromosomes are deactivated during the evolution. But it's not like that. Sometimes it's not totally deactivated. So why it's deactivated? Because a coating of RNA and some kind of proteins protect the genome of the X chromosome, but sometimes it's not, that coverage is not complete. So some genes may exacerbate, and it's very interesting that some of genes may help to perpetuate the inflammation and perpetuate the inflammatory reaction. So understanding that plus the new understanding of actually, it's very interesting. In some autoimmune diseases, we have some autoantibodies against that coating as well. So it's very challenging, very complex understanding of the role of the X chromosome in autoimmune diseases, and we can interpret maybe the X chromosome is showing more genes to help for inflammatory reactions in the women. And the other thing that's very interesting recently, and it's the role of the actually the microbiome inside the body and its role in autoimmune reactions. One of our colleagues at Stanford a couple of years ago showed that the role of the microbiome inside the gut, inside our intestine, how it may help to perpetuate or decrease the inflammation inside the body. So it's very interesting to know that we have different microbiome in different people, also in terms of the sex between men and women. So this may be another reason one would like to actually explain the differences between the immune reactions of men and women. Also, we know that the genes that actually underlie the immune reactions, like CTL4 and other genes, are basically different in different people. Maybe the expression of these genes in women are more than men. So, there are a couple of things, as you mentioned, maybe women are more emotional, and we know the fluctuation in emotions may somehow affect the immunity and immune reactions. So these are the basic differences between men and women, can explain somehow why we are seeing much more autoimmune disease in women compared to men. And I may add also vitamin D, that's more, actually vitamin more deficiency is more prevalent among women. That may be another reason for that underlying autoimmune disease in women.
Well, that was incredibly insightful information. Now I'm going to go look up the X and XY chromosomes levels to that. But no, to your point, just, to sum it up, and then I'd like to know Dr. Van Landingham's, because she's a female in the profession, and, I'm not saying anything about you guys, but if 25% of, 1 in 4 people, women, get autoimmune conditions, it's sometimes challenging in my position to go to a man and then telling me that I'm emotional. So I'm not saying it's a good thing. I'm just saying it's a women thing. So Dr. Van Landingham, what is your insight on the females getting disproportionately affected about hormones, and what your thoughts are? And while you can add that, I'll tie in my second question. Who should be on their medical team? Anybody who lives with thyroid eye disease, because it affects both men and women. I'm not forgetting about you guys out there, but could you answer that question?
Sure. Yeah. So thyroid eye disease disproportionately affects women. Interestingly, tends to be more severe in men when it does present in men.
Wow.
Yeah. And I think there are a lot of theories out there as to why women get autoimmune diseases more, which I think Dr. Pactel very nicely went through. I think, to me, the ones that are the most persuasive are the role of estrogen in sort of potentiating or helping our antibodies to work. And especially with estrogen levels fluctuating throughout life, just kind of thinking on a very basic level, if that hormonal milieu, that kind of hormonal soup in our body changes so frequently, kind of makes sense that may trigger some instability in the immune system. So to me, that's the most persuasive theory. I think there's some more recent excitement about the need to inactivate one X chromosome in every cell in our body. So women have 2 X chromosomes, men have 1, and because of that, the second X chromosome in most of our cells is inactivated. And there was a recent publication, I thought it was out of Stanford, maybe it was, but where something about that inactivation can trigger the creation of antibodies. And sorry, go ahead.
No, that's amazing to hear.
Yeah. And, I think in terms of who's on your team for thyroid eye disease, I think the way that team is built really depends on what sort of symptoms come first, person by person. So you might be someone who gets Graves' disease discovered on routine labs. So you first find an endocrinologist, and then later your eyes start to change, and then you find an ophthalmologist, and then an oculoplastic surgeon. Or it may be that you, to the best of your knowledge, you're completely healthy, then all of a sudden you get double vision and you don't know why. So you kind of start with the eye route. So I think the way that team is built really depends person to person. I think for anybody with thyroid eye disease, seeing a ophthalmologist with expertise in thyroid eye disease, for the most part, that'll be oculoplastic surgeons, because we kind of do the reconstructive surgeries that are primarily that are needed for thyroid eye disease. That's kind of person number one. Obviously, I'm a little biased. There are also certainly neuro-ophthalmologists who have a lot of expertise in this area as well. So one ophthalmologist with expertise in thyroid eye disease. Two, I think connecting with an endocrinologist is important, mostly because most people with thyroid eye disease do have some kind of underlying a thyroid hormonal abnormality, mostly Graves' disease or autoimmune hyperthyroidism. I think it's important throughout this to not lose sight of kind of keeping up with your primary care doctor, just because a lot of times it helps to have that one kind of central person connecting some of the dots and helping with referrals. And then, I think it's important really not to forget mental health. Obviously, this can be an immensely stressful disease. I don't need to tell the people on this call this. And I think it sometimes, with all the juggling and the balancing of what doctor do I see for this, who do I see for that, who's a network, you do kind of want to make sure you're attending to your mental health. And not that it's easy to kind of find the right provider, or really any provider. There's shortages of mental health providers, but I think seeking, if you feel it's necessary, kind of seeking an early referral to either say health psychiatry or health psychology. That's a specialty where they kind of specifically work with people adjusting to medical diagnoses. Or a therapist, or pastoral care, a chaplain, if you're if that aligns with your faith tradition. I think that's important stuff to remember. I will say I've started, after meeting Christine, a while back at one of our professional meetings, I've started giving patients the name of the TED community organization at our first, at that kind of first diagnosis encounter. We kind of have a packet of a lot of different material, and mostly because can be very overwhelming learning about this new diagnosis and all these different things you may have to do, or things to do or not to do. But I think for a lot of my patients, I found it's really helpful to be able to connect with others with the disease, online, in part because it's a rare disease. You may not know somebody in your life who has it as well. So yeah, I think that's been really, really immensely helpful. So ophthalmologist, endocrinologist, primary care, and as needed, health psychology, or somebody to be in your corner for your mental health.
And then tedcommunity.org, we round out the
Yes.
entire thing.
Yes.
All of us trying to understand what all of you amazing doctors are saying to us while living with the condition. So this is great. I was going to ask, I think Dr. Ayala had to put some questions up there about smoking. So there's what we hear is smoking is a big risk factor. Can you tell me and explain, why does it play such a big role, and can the damage be undone if someone quits?
I think smoking have a 7 times risk of develop of thyroid disease. I think there's a number of basic science research I've looked at. Smoking, exposing cells to a smoke material does alter the kind of it produce oxidants, kind of reactive oxidant species in tissue, and we think that that's probably what caused the smoking, give you more chance of getting thyroid disease. And also, I think Dr. Van Leeuwenhoek mentioned that can make it worse as well. And I think because of that, we advise people to at least cut down if possible. I mean, obviously, it can be a challenging situations. You're in a stressful time that's induced your autoimmune, and then now then people tell you to stop smoking. That's even more stressful. And so I think it's very tough situations. And I'm in Appalachia, and so it's very difficult to do that there. And the study I've looked at, your percentage of risk of getting TED actually decrease with the number of cigarettes you cut down per day. Number of cigarettes you smoke a day. So I think it's a modifiable factors. It's not easy to do. I have patients who have cut cold turkey, and I don't think that by cutting away the smoking, stopping it will stop the disease process in terms of reversing. But I think you're protecting yourself because there's patients who develop compressive optic neuropathy while smoking. And so I think that's a very, damaging and potentially blinding situation. So the more that you can cut down or quit smoking, the better that can be. So I think, if nothing, it will protect you from getting worse potentially. But I think it can stabilize your disease by quitting smoking. I think nowadays, since you mentioned smoking, we have people who are vaping or using other kind of non-traditional nicotine based. I think it's a little we don't have a lot of data for those. I think if I remember, there was a study that looked at cannabinoids, and I think they didn't find a difference, if I remember, much difference in terms of rate of thyroid disease. But in terms of e-cigarettes versus traditional cigarettes, I don't think there's any study that look at that. But my colleagues can chime in on those on the experience and if they have other opinions about those.
Well, we have about probably about 7 more minutes before we go to the Q&A, and I'd like to talk about Dr. Pagdel's biphasic. I'm going to share my screen. Can you guys see that? Can you guys see that?
Yes.
Okay.
Yeah.
Well, if I get out of it, my question was there, but can you help us understand like an active phase, a stable phase, a plateau phase, and why does it keep coming back? And just for my condition itself, I got it in 2015. Obviously, I had it in 1998. It reactivated, and then I was on a like plateau roller coaster of never really having a stable phase. And then like even today, stable for me is still considered diplopia, which is double vision. Like as long as I can manage it, it's considered stable. So can you help us understand active versus stable and why some symptoms will still be in both, so we don't feel like there's a cure, because there is no cure? I'll let you go, and then someone else can chime in, and then I have one more question at the end, and then we'll go to the Q&A.
Well, thank you very much, Layla. So this is an essential understanding about the course of thyroid eye disease. So if you look at that, you may imagine that's very similar to kind of different autoimmune diseases. We know that many autoimmune diseases in the body, they are in some time they are active and then they spontaneously fade out and may recur months or years later. So thyroid eye disease, actually, when we talk about our active phase, it shows that we are seeing progressive worsening of the clinical symptoms and signs, and also we are seeing worsening condition in other, paraclinical like imaging or lab data of the patient. For example, the patient is experiencing progressive proptosis over months or progressive actually development of eyelid retraction, or shows some erythema or redness of the eye and eyelids and puffiness and swelling over the ocular surface or eyelids. So this is called like active disease when we are seeing symptoms and signs and some other measures of disease is showing worsening. And usually it worsens up to like a few months or years. Usually the course is 1 to 3 years until it subsides spontaneously. So at the beginning, you will see an ascending phase. Everything is worsening in the first phase. After that, it reaches a plateau. For a while, the patient is not experiencing any further, everything shows stabilize, and after that slowly comes down, but maybe proptosis and some changes are not returning to the basal initial level. So if you follow the patient for like few months or years, 6 months or 1 year or 2 years, you may see that there is no further change. This is the period we are saying we are now in the burnout phase. It shows no further inflammation occurs inside the orbital tissues. And why it's essential, what these two phases, active and stable phase, are essential, because it's the essential understanding of formulating the treatment when the patient is experiencing the active state, the inflammation is active, cytokines are showing high levels inside the orbit, or tissue remodeling is active. That's the point. We need immune modulation for the patient. If the patient with proptosis, like in the stable phase, we start IV methylprednisolone or many of other immune modulating agents, it may not be helpful for the patient anymore. So the most effective phase for starting anti-inflammatory agents would be the first active phase. But as you beautifully mentioned, I was amazed how beautifully you described the disease. So it's oversimplification of the disease by just saying we have active and in stable phase. Usually it's not like that. 15 to 20% of patients show multiple hump phases. It's not like simply one hump and then everything settles down. For a while, the patient shows inactivation, but again, the patient experiences some worsening of the condition. So in reality, it's not like that. It floats up and down. So, remember, we're talking about that thing, just changes in the symptoms and signs, or MR imaging doesn't show what's happening in the molecular phase, or in microenvironment inside the orbit. Maybe there are some activity over there, but we are not seeing there. They are just waiting for some more hormonal changes, some emotional changes, some thyroid imbalance to show themselves, or even surgery. Surgery is kind of a stress for the patient, even decompression or eyelid surgery, like blepharoplasty. We are seeing lots of patients that, undergo surgery prematurely before we make sure that the patient is in the active phase, and then the patient floors actually shows some exacerbation in the proptosis again, pain and swelling again. That shows the patient was not really in inactive phase. That's why my colleagues like Suzanne, John, Dr. Hunt advise the patients, we need to make sure you're in active phase before proceeding for the rehabilitative surgery, unless the patient is in the emergency situation. So this is the basic understanding of us. And I may add one more if I have time, that this understanding that we traditionally formulate our treatment for anti-inflammatory agent based on the active phase or non-active phase is not anymore valid, because based on our new understanding that we can modulate actually tissue remodeling even in the chronic stage by new drugs. Maybe it's not true for some of the drugs like teprotumumab. We know that even in those patients with the chronic non-active stage, we can actually change in the patient symptoms. So it doesn't mean that if the patient is in the active phase, that some drugs may not work for the patient. So, there are some new things that happening for our understanding, but the essential thing is that what happens inside our body in terms of the active and non-active phase.
No, well, that segues me into my last question, which is our last few minutes, but you're right on. Like when I took the medication in 2020, they got tested for 8 sessions, 3 weeks apart, because that's what they knew, and that's where they got the best results and the most efficacy results between the pros and cons of what people had the side effects on. And as you guys are learning more and more, maybe you only need 4, maybe you only need this, and maybe we have to tailor these medications and new technologies to our patients. The challenge is, which I'm not going to touch in this session, is medical insurance, but I won't touch it. I'm not touching it. All I'm saying is that as powerful patients and confident clinicians, if we collectively connect together, which I'll go to my last question in a second, is that we can make those changes and we can make those differences in tailoring those medications, just like you said. And that was, you said it. I was going to ask you if each of you could tell me one thing you'd like to clear up on a myth about thyroid eye disease and the science behind it, or what you're learning now, or maybe a common misunderstanding about TED, what would that be? And so I'm going to try to make this short and sweet, 90 seconds each, 1.5 minutes. Dr. Pactel already went. So what about Dr. Van Landingham? And then we'll go down.
Oh, thank you very much again. So I may say something like, most of the patients believe that thyroid eye disease is only associated with hyperthyroidism, and I ask why my thyroid is not hyperfunctioning, why I'm developing thyroid eye disease, or I have like hypothyroidism. I have no thyroid dysfunction at all. What's happening? So this is based on understanding that most of the patients, like more than 80% of the patients of thyroid eye disease, have hyperthyroidism, but some of them may have hypo or euthyroidism. So it doesn't mean if you have hypo or euthyroidism, you cannot get thyroid eye disease.
That means thyroid eye disease doesn't care who you are, it will still attack you.
Yeah. So should I add more, or?
I'm going to just go to the next person because I've got 2 minutes left.
Of course.
But you guys will have 10 minutes of Q&A.
So I'd say the most common myth that I'd want to clear up is just there's no one size fits all treatment. Treatment has to be tailored to the individual, both the way TED shows up in them, their other illnesses, as well as just their own kind of personal needs and their personal story. Just for example, Tepezza, great medication, not great for every single person.
Right. Thank you for that. Dr. Hong?
So the vast majority of thyroid eye disease patients present with what we call mild disease. They may have mild proptosis, eyelid retraction, where main symptoms are just eye redness and irritation, contact lens intolerance, for example. And so I think early recognition by both clinicians and patients is important because I think it can easily be missed and attributed to other things like just dry eyes. And of course, when it gets to the moderate severity or severe severity, where you actually have double vision and you have severe proptosis and vision loss from optic nerve compression, of course, it becomes a lot easier to recognize. But I think it's really important to try to recognize it early, because now, especially now, we have treatment modalities that can actually intervene and be very effective in treating this disease in a very accurate and targeted way.
Yeah, no, great. Early detection, prevention is the best cure. Catch it early. I love that. Dr. Nguyen, and then we'll end with Dr. Ayola Hayud.
I'm gonna add kind of a combination of what Dr. Hung said and Dr. Padel said is it's an autoimmune disease. For TED, it can have ups and downs, meaning you can have bumps or flares. So we have new treatments such as tupilumab that can help. However, as we learn more about the disease process, we know that there'll be times that you can flare or relapse. So it's not a matter of you fail a medication. It's just that, like in an autoimmune disease, you have to treat them at that time of what you need. And I think as we find out more that, how do you tailor the treatment for those flare that you go on? Not everyone have flares, but when you do have that, then we have to figure out what is the next step, what's the best for you. So don't think of, patient can have a thyroidectomy and they're set for the rest of their life. That's not the same thing with TED. You can have flare.
I know. I'm so disappointed. Ugh, took on my thyroids and then I still have it. All right, Dr. Ayula Hayedo.
Thank you, everybody in the panel. To follow up, Dr. Wynn, that we have a question here that is asking, why do patients flare after a successful treatment, such as, for example, surgery? Can the panel comment on their experience?
Oh, sorry. I guess that's a question to you guys.
Yeah.
Now we're doing questions.
One thing I find many times patients come in with a new stressor, can do that. Patient can be relapsing with smoking. That I find that to be a triggers. But certainly I think we don't know. I think it is the one of the big mystery. But I guess if more studies needed to find out why patient shouldn't flare.
I don't like that answer, but I will give it a whirl.
Anyone adding anything else before I move to the next question?
So yeah, I may add very quickly if we have time. Actually, as my colleague Dr. Nguyen beautifully mentioned about different factors that now we understand can affect like iodine therapy, like smoking, like emotional changes, like hormonal imbalances, like imbalances in thyroid, especially induced hypothyroidism. Some patients during treatment for hyperthyroidism experience, periods of hypothyroidism, and it may increase the risk for flare-up of thyroid eye disease or exacerbating the pre-existing condition. And maybe the basic understanding is that we should consider that we have like underlying inflammation in molecular levels in orbital tissues. So we need just to consider that every new change may help to flare up that pre-existing condition for the patient.
Thank you. So I have another additional question that I want to ask. What is the role of biomarkers? Specifically, they are asking, how helpful is to follow TSI or other antibody levels once the diagnosis is made? Dr. Van Langdingham, please, if you can comment.
Sure. So I think we know that TSI, or thyroid stimulating immunoglobulin, and TRAB, or thyroid related antibody, are tests that can measure antibody activity in thyroid eye disease. I think there's not a great consensus on how often to test and how to use those results. Personally, I like to use those lab tests to help make a diagnosis of thyroid eye disease, and then also to help detect flares. Say somebody has a high TSI level when they're diagnosed. After their symptoms seem to have resolved, they've been successfully treated, their TSI is low or even normal. If we think they might be having a flare later on, you can test that lab again and it can help you figure out if it is in fact a flare, and therefore help you guide treatment and get treatment started early if needed.
Thank you. Anything else that you would like to add? Any other member of the panel? Dr. Hong?
Yeah, I think TSI is very important. I use it a lot when I'm questioning the diagnosis of a thyroid eye disease, like in somebody who presents euthyroid, and you think they might have thyroid eye disease. I'll order that. I don't really use it to follow patients as I'm treating them, but I think it can be useful in if you need to know their, I guess, response to therapy, or if you're just kind of curious as to like where in their phase of disease they might be in, because the higher it is, the more active it correlates with the activity of the disease. So you could use it that way, but I think just clinically, I don't use it really in that way too much, but more for diagnosis in those like tough cases.
one other member of the audience is asking whether like smoking cannabis like has the same like a harmful like association with TED. Like if we can have another member of the like, audience, like the panel answer that.
I know I just spoke, but this is a question I think is really exciting, so I wanted to speak up. So I think the simple answer is maybe. This is a new and active area of research. It's something I've been working on some at UW as well. But basically, while we think that smoking triggers and incites thyroid eye disease via oxidative stress, we don't know, smoking cigarettes, we don't know exactly what chemicals and exactly what toxins within cigarette smokes is the most harmful. Now vaping is relatively new and a lot more, pretty popular. Cannabis use is legal in many areas and less stigmatized than it was 10 and 20 years ago. So it's also becoming a lot more common. But in part because that's newly usable, it's been a challenge to study. And I think both from a regulatory standpoint and also, people may not be very forthcoming about their use, for good reason. But anyway, so it's an active area of research, and I think the preliminary studies that have been done so far seem to indicate there's probably not as strong of an effect of cannabis use or vaping compared to tobacco, cigarette smoking on thyroid eye disease. However, there may be an impact. So I'm getting that question a lot from patients, and some, usually what I say is, well, if it's something like, well, I really can't just completely quit cold turkey, but I think I can switch to vaping. I say, okay, great, do that. That's probably less harmful than cigarette smoking, but I can't tell you it's harmless. And, we also know that none of those things are good for you. So it's better to kind of stop any of those substance usages if possible.
I think there's a
So
good last question if you're good with it, but there's that two-part
yeah.
question. What is the latest understanding of how long TED lasts before it burns itself out? And then when it does burn itself out eventually, are the symptoms typically subsided or do they become chronic and permanent? Anybody? I feel
Dr.
like it's
Pagdel,
chronic
you
and permanent
alluded
for
to
me.
you alluded to that like when you showed the graph like with the active and like inactive phase or stable.
But it's talking more about symptoms, like in general, like are the symptoms for life? And I've been living it for 27 years and I still have diplopia. So, I mean, I think everyone wants to know like there is no cure. So, what does burnout phase look like for people just based on y'all's experience? If you can answer that last question because the next person's about to start.
So the
So my
active phase, I think, is, and we used to say like 6 months to 2 years, just kind of average, and then you enter the chronic stable phase of the disease where things aren't supposed to change. But now we know that this is not just strictly like monophasic, and you can have multiple phases where multiple relapses. And so I think some of the changes that you do get, like through the proptosis and the fibrosis that leads to restriction of eye muscles is going to remain even when you enter that stable phase. So I always tell patients that you're not going to go back to your pre-morbid state before you got this disease. It'll just stop getting worse when you get into that stable chronic stable phase. And now we have to tell them that also your disease may actually relapse again later. And sometimes it can be like many years before like it relapses. Like I have like elderly patients coming in relapsing like decades later. And those, by the way, anecdotally I've noticed that when they relapse very late like that, they tend to be more severe. I don't know if you other panel members have noticed that too, but I mean those can be quite severe and sometimes like sight threatening.
Well, we're out of time. So I want to thank everyone on the panel to help us understand the science behind the thyroid eye disease, and for everyone who's joining us for the rest of the day. The medicine is coming up next. So it's tying in the science to the medicine. And then all week long, we're learning about how to live with the disease from the esteemed people on this panel, as well as those on the other one. So thank you so much for sharing. If anyone wants to reach out to them, obviously you can take a screenshot of their names and search them up on Google, or join us at tedcommunity.org, because Christine knows every single one of these people personally and will give you their contact information. See you at the next one.
Thank you. Bye-bye.
Thanks,
Thank
everyone.
you.
Thank you.
Thank you.